So we're going to review murmur, chest pain, syncope, and we're going to talk abnormal EKG, and then we will finish with take-home message. So congenital heart disease, as you all know, incident about 4 to 5 in 1,000, but most of this patient, they die before birth. We end up with about 1%, more or less. We have cyanotic, non-cyanotic, obstructive, left to right shunt, right to left shunt, and so on. So this is all. We are not here to talk about this kind of things today. So we're going to talk about when to refer. So first one, the commonest thing I see when I am in the practice is heart murmur. Before you refer to the physician, to the cardiologist, about heart murmur, first we have to learn how to use the stethoscope first of all, and then to decide what we are going to refer is make sense or not. So chest pain, shortness of breath, syncope, Kawasaki disease, palpitation, arrhythmia, and genetic syndrome. So this is the main reason why I see patient on the pediatric cardiology clinic. Of course, I'm talking about the normal situation where we don't have really an emergency situation like in the ER or a newborn baby. These are not part of our talk today. So we get also referrals because they need surgery, they need clearance, school needs something, especially right now we see a lot of patients just because of COVID, and the patient is positive, you need clearance from the cardiologist or from the pediatrician or from so on, and then we get a referral for hypertension and obesity. So the pathway for proper referrals is the 3A, what we call it the 3A, and actually this 3A is valid for everything we do in our life, especially in medicine. So the first one is availability, that, Dr. Migdadi is available and I can find him when I need him. So if he's not available, that's a different story. The ability is the second thing, that I trust this doctor, he will do the job properly, and then the accessibility, that you're going to be able to see the doctor. If you come to the hospital, they're not going to turn you back, you cannot go and see him, you don't have insurance, you are not having this ID or so on. So what a barrier that we, actually it's not only for pediatric cardiologists, probably for everything else. So lack of resources, ped cardiologist not available, so this is a major problem. Lack of equipment, we have a pediatric cardiologist, but maybe he doesn't have a cath lab, maybe there is no good echo and so on. And the other thing that we see, especially in pediatric cardiology, care offered by non-properly trained physician, and most of the time, I'm not saying in a good or bad way, but most of the time our pediatric patient getting taken care by adult cardiologists. And I am sure, you'll see that mimicking itself in other specialty like GI, neurology, where with time, pediatric subspecialty become more well-known and become more people more aware, and our pediatrician become more aware that, we should refer to our own pediatric subspecialist rather than adult. And then, of course, congenital heart disease and the coverage is a major issue, cost and patient compliance. Sometimes you send the patient, go see the doctor, and the patient just, doesn't come. This is a very common slide. I use it almost in different presentation. And this is what I'm talking about. This is for normal child, for normal baby, newborn, 24 hours, how we recognize when to refer to pediatric cardiologist. And I'm talking about this 3 column as a normal baby. I'm not talking about baby who's in the intensive care or who's very sick or in the ER. I'm talking about normal newborn baby, 24 hours later. When do you need to send him for a pediatric cardiologist? Of course, this is not, it's just one of the things that we do, but we are missing the the physical exam, which is not added to this slide. But from this slide, as you see, the first one is the red line. So if 24 hours, if you check the saturation, it's mandatory right now to check the saturation, and I'm sure you're all aware that every baby after birth, we have to check their saturation. And what's more, I will advise you to make sure your nurses really, really check the saturation. I still see it in my own office, probably time to time, that, the nurses, they assume normality, and we all assume normality. So you write saturation 99%. Just for that reason. So make sure they are doing it properly because they, for whatever reason. For the baby, if you have a saturation on the 90% or less, or different more than 3%, this patient need to be referred immediately to pediatric cardiology. So you have to call the pediatric cardiologist, hello, I have immediate consultation and I need you now. It doesn't matter what time it is. So the next one is, the green line. This is after 24 hours, so more than 95 or no different, less than 3%. This patient, they can go home theoretically, assuming their physical exam is normal. If I don't feel the femoral pulses, even the saturation is normal, that's not enough for me to clear the child. Okay, the third one is the one in between, which basically we keep them another 2 hours, so they are between 90 to 94. You keep them another 2 hours, check them after each hour. If they still under 94, that's another immediate referral, not tomorrow, not next week, now. And I mean to send them to pediatric cardiologist in somehow in an urgent way. Going back, the most common thing is the heart murmur. So, what is the heart murmur? Heart murmur is just sound related to cardiac anatomy, or it's just mean always hole in the heart, or it's just turbulence of sound of blood. Bottom line, anytime we talk about heart murmur, it's a turbulence of blood. So the blood is going through a pipe, and this pipe either big or small, or there is a lot of things going, if in the pipe is normal by itself, like in VSD and so on. So which one that, you have to do whenever you hear a heart murmur? So the most important thing, comprehensive history and physical exam, echocardiography, EKG, chest x-ray. Which one is the most important? And of course, we'll always say the most important thing is comprehensive physical and history for the patient before you do anything else. All right? So definitely ECG is available for us, so it's easy for you to do. It may not give you what you are looking for diagnosis, but it may be a starting point. Chest X-ray, I personally rarely ask for it for the pediatric cardiac point of view, because there is so many other things that, but it may be good for the chest itself, for the parenchyma. But for the heart, it's not going to tell you if the patient have hypoblast as an example, or has just a normal heart, with a few exceptions, of course. Which of the following is true about gradient of the murmur? So grading heart murmur is somewhat provider dependent. Of course, we all know that, somebody will hear a murmur, somebody will not hear it, somebody will have a good stethoscope, somebody will have a Chinese air. There is different variable. I hope you don't have a Chinese air. I mean, you could have, if you are Chinese, of course. So, but the point is that the heart murmur depends on who's examining the patient. So if you are considering all the time, I'm listening for the chest to see if there is any rales or any ronchi or any wheezing, then that's what you are looking for. You have to switch your brain. Okay, I finish with the wheezing and finish with the parenchyma, whatever I'm looking for. Now I need to listen to the heart sound or the heart murmur. You have to think about it in a separate way, not just to show the parents that you have done the job. Of course, the higher the grade is, the more likely there is a significant heart disease, especially within exceed 4/6. So murmur occur about in 50% of the children. So when you count this number, I am not asking as a pediatric cardiologist, you need to send 50% of the patient that come into you in the clinic, but you have to know how to select the one that you need to send to the pediatric cardiologist. As an example, maybe I'll listen today. If I'm not comfortable, I will send. If I am comfortable and I trust the parents, they will come back, they will come and follow with me. I will let them go, come back in 1 month or 2 months, according to how you feel about the situation. And then I will know that this patient, they will come back. And if I need to send, I will send them. So out of this 50%, only 2 to 7% of the heart murmur on the children that they will have a heart disease, and most commonly a bicuspid aortic valve and some other things. The location and the grading and the timing, I'm not here to teach you the primitive stuff that we study in medical school, but this is all important for us to decide about the heart murmur. Symptoms. So there is heart murmur come with symptoms. So if the heart murmur come with symptoms, it brings more things to me that this may be something that not going right. So asymptomatic could be ASD. You could have a 50 years old man with an ASD secondum 1.5 centimeter as an example, and he's been surviving all his life, and even he may have Eisenmenger syndrome or whatever, and still it's one of the things that I always tell the parents, that the heart is a quiet organ. No one knows what is in your heart except you and your wife, hopefully. And even your wife may not know, or your husband. But the heart is a quiet organ. Unless you find somebody who's 50 years old and next day they say he's in the intensive care unit. In the same manner for children. A child who has normal after birth 24 hours, go home, come back to the emergency room dead. Why? Because we did not recognize the obvious, not because there is no problem or there is a problem. So there is something with cyanosis. Cyanosis is a very vague. I don't know how many of you have diagnosed heart disease just by cyanosis. Because cyanosis, first of all, depend on the color, depend on the way that you look. If you look inside the mouth and you see cyanosis, that's the cyanosis. If I look at your hand, lips, outside here, which is a very, very common complaint. I get at least 3, 4, 5 patients a week from blue around the mouth, and that's basically normal. I'm happy that you sent that patient, but I'm just telling you that's normal. So syncope, this is, patient with syncope related to the heart. That's a very serious issue. Stenosis of the aorta or the pulmonary artery is a very significant thing. And then heart failure. That's people, all of these people will have symptoms. So any patient with symptoms, you should refer them. And cardiogenic shock and so on. Red flag, very important red flag. And I want you to remember this. Family history. Family history. Family history is probably the most important for detecting, not your stethoscope, not your ECG, not your echo, not whatever. The most important thing is to ask about family history, because that's what will save life for you, for patients, especially when we talk about sudden cardiac death. And family history, we are talking, before I go to the others, we are talking about, high cholesterol, high blood pressure, high obesity, diabetic, somebody died at 40 years old, we don't know why, somebody died at 20, even if it's not cardiac, it's always a red flag. Any patient in the family die at a young age with no specific reason, that's automatic red flag. Need you to pay attention to this family and tell them to go and check themselves out. So of course, failure to thrive is one of the reasons why you should consider referring a patient for screening of congenital heart disease, poor feeding, irritability and so on, diaphoresis, or unexplained symptoms, respiratory symptoms, tachypnea. We see 5 years, 6 years, 5 months, 6 months, patient with just, admitted again and again and again for bronchiolitis. You end up with something related to L-CABA as an example, or related to vascular ring. And people have been, and at least twice a year, I see this kind of patient. And this patient has been admitted many, many times for different things than a heart disease. The most scenario I will always remember about congenital heart disease, a 20 years old lady, Down syndrome patient that come to the emergency room almost 3 or 4 times a year, and she ended up by having AV canal and Eisenmenger, and all this time coming to the emergency room 3 or 4 times, 5 times a year, treated for eczema. And she's Down syndrome, and nobody detected that this patient could have something. Of course, when she was born, she wasn't, in a faraway village or whatever. No, they don't have any equipment. But then they moved to the city. People should have pick it up. And she's Eisenmenger. She's already cyanotic. She has clubbing. You just feel what's going on. We took whatever somebody wrote before, and we take it as granted, and she has eczema. Let's treat eczema. So always think behind, the general thing, what everybody else thinks. By the way, for cyanosis, to really say there is a cyanosis, you need a patient who has less than 85% of saturation to say he has a cyanosis. Imagine how many tetralogy fellow, as an example, will have less than 85%. Almost rarely you will see them for the first time as a pediatrician. So think about it with some, of course, Gallup, Clark, and so on. Again, family of sudden cardiac death is a big deal. red flag. It's in older children, the chest pain that come with exercise. So that's not normal. I run, I feel pain. That's not normal. I have to check that, make sure that you syncope, especially syncope come with exercises also. That's a very, very serious thing. Exercise intolerance. Every time I run, I have to stop. Everybody in the class end up, 200 meter, and I stop after 50 meter. That's not normal. I don't care what is the reason behind it. Maybe you're just not conditioned. Maybe it's just a simple thing because you are not exercising and you are eating McDonald's all the time. But it's worth to investigate. No matter where it gets you, it's for the good health of a child. You are right now in a preventive way, if not in the treatment way. This is a common thing, 6 months, everything is beautiful, no problem, eating fine, and the heart murmur was heard. So I will start thinking, do I need to refer? Do I not need to refer? Is this heart murmur, what grade, where it's located, what's this child, febrile, not febrile, anemic, not anemic? I will start, but I may not be concerned if everything seems normal. But if I examine this patient, the same patient, and I found, there is the pulse is diminished, then that's a problem right there. So you have to combine whatever your stethoscope with the rest of the history and the physical exam. So this is red flag for chest pain. That's you can keep them in your mind. Dizziness, nausea, syncope, all of these kind of things. And again, family history of sudden cardiac death, the biggest red flag of all. Because it's just a drama. You just need one and the whole country will know about it. Syncope, we see the most common neurocardiogenic syncope, which is a very much benign thing. But there is some of the syncope that I need to be more vigilant. And syncope specifically, it brings the family so much worry. And most of the time I will say, I want to see this child, not because I think I'm going to make a difference, but because of the reassurance that needed for the family. Imagine their child in front of them fall on the ground and they don't know what's going on. So they are very worried. They need a lot of reassurance. If you think you are comfortable to give them so, that's fine. Otherwise, you should refer them for that reason. I'm going to try to finish this. So syncope with exercise. Patients have syncope while driving as an example. This is not acceptable. I hope I'm not going to be one of those patients. Or with emotional trigger, this could have abnormal EKG related to long QT. So if the patient is crying and suddenly have syncope, that's not normal. Or a patient who, I have a very nice history of a family with long QT syndrome was treated for seizure for many years. And then her brother and sister, they were hiding behind the wall, and then every time they will scare her and she will fall down, and they were thinking about it as fun. And finally she was treated for seizure. One time while she was having a seizure, I was attending in the floor in that month, and just by accident she has the monitor, and we went there inside the room by accident, and we saw she is in ventricular tachycardia. So we ended up by having this patient as long QT. She had a pacemaker for her, defibrillator, and so on. So everything that you have to keep in mind, you have to make sense out of what you see or what you hear. Of course, if you have syncope with abnormal EKG, that's a very big problem. Palpitation, very much common. I don't know if I still have time. Last minute. So there is, hypertrophy with palpitation. That's a very serious things. The palpitation could most of the time, I'm just scared. Somebody's scared. I'm excited. So I have a lot of ladies, very much. I work with my colleague, adult cardiologists, 3 of them. I think at least 80% of their patients' number is palpitation, and more than 60-70% of them ladies. So this is a very common to feel your heart rate. And for us in pediatric, we see them usually as a teenager. So they come to us, my heart, I feel it's going fast, and so on. I think I'm going to stop here just because I don't want to, this is a very common thing. This is what we call it PAC, early contraction. It's a benign, nothing for you to worry. If you do an EKG and you see this, where is it there? You see it's around the circle. This is a very benign thing. It's compensating in the next QRS. and R2R interval. You can see it even in the area down on the pulsation. This is a premature ventricular contraction. Anything come early is okay as long as they don't come in train. Anything come in train, that's bad thing. If you see 8 BVCs as an example coming after each other, or 3 coming after each other, or 5 coming after each other, that's the reason why to have a low cardiac output. You only have a syncope from arrhythmia because you have a low cardiac output, because your heart is just doing this or going very, very slow. Okay, I think I'm going to stop here, and thank you very much to all.